نبدأ بسم الله. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين. في حد في الحضور مش بيتكلم عربي؟ في حد حابب يتكلم معاه بالإنجليزي؟ Anybody need to talk in English؟ طيب نتكلم بالعربي خلاص؟ أوكي؟ ميكس ما يبقى ميكس غصب عني بس مش كله إنجليزي يعني خلاص؟ طيب المحاضرة النهاردة بسيطة خالص. موضوعنا البنج الموضعي Regional Anesthesia. هنتعرف شوية يعني على البنج الموضعي. هدفنا من المحاضرة دي نعرف إيه أنواعه، التعريف، ونزيل شوية شكوك أو مشاكل أو قلق في ذهن المريض أو في ذهن الدكتور أو اللي هو مش تخدير عن التخدير الموضعي. يعني عايز الحضور اللي مش تخدير يعرف إن إزاي ما يكلم حد هيعمل عملية قريبه أو يكلمه عن البنج الموضعي، يعرفه إيه هو التخدير الموضعي ويعرفه إيه المشاكل اللي ممكن يواجهها ويزيل من مخه المخاوف أو الرعب اللي ممكن يقابله. وهنتكلم في الآخر عن الفوائد والأضرار pros and cons of anesthesia أو regional anesthesia. في حد معانا بالإنجليزي فهي will talk in English خلاص. This is our anesthesia recipe, very easy and very simple and very cheap. Okay. بسم الله الرحمن الرحيم. First slide we will talk about the meaning of anesthesia. Word anesthesia. Word anesthesia of two parts. An means no and anesthesia which is sensation. So anesthesia means no sensation. ما عنديش إحساس. إيه معنى كلمة sensation? What is the meaning of sensation? Sensation is not simple word. It means a lot of meanings. Sensation means tactile, touch. How to feel touch. أحس حاجة ماشية على إيد. Something is moving on my hand. Tactile sensation. And temperature. Is it hot or cold? Position. My hand in front of my head or above my head. My finger is standing or bending. Vibration. Something is vibrating on my hand like an insect moving on my hand. And lastly, pain. So sensation means a lot of meanings, including pain, not pain alone. So I can feel something which is cutting in my skin, but it's not painful. Okay? Types of anesthesia. We have two major types of anesthesia, general and regional. Today, our concept is regional anesthesia. Our perspective or our scope of talking is regional anesthesia. Firstly, I will talk about the definition of general anesthesia. It's a drug-induced loss of consciousness during which an individual is not arousable even by painful stimulation. So I will put my patient in a status that he is not conscious. But in practice, I don't mention the sensation. So the first aim of general anesthesia is to lose consciousness, plus or minus sensation. But keep in your mind, if I lose consciousness, I will subsequently lose reflexes, and I cannot take my breathe spontaneously, and I may obstruct my airway. So GA, general anesthesia, needs a greater support to maintain the physiological status of the patient and to open his airway. On the other hand, the regional anesthesia simply to make a specific part of body numb to relieve pain or allow surgical procedure. In another word, loss of pain sensation in a territory. A part of my body, my finger, my hand, my arm, even my lower half of the body is not sensing any sensation. But keep in mind that I am not talking about consciousness. I am talking about sensation. So I will lose the sensation, not the consciousness. We have a lot of types of regional anesthesia. The most common and popular is spinal anesthesia and epidural anesthesia, in which I will lose a half of my body sensation and other blocks like hand block, arm block. So I will lose sensation in a part of my body, a finger, a hand like this. Again, where is consciousness? In the last definition of regional anesthesia, I didn't mention a consciousness. I will be awake. Yes, the patient will be awake. So I will lose feeling while I am conscious. Amazingly, yes, you will lose feeling, but you are still conscious. This is very confusing. How I can lose sensation and I am still awake. Remember, you can feel no pain while you are awake. ممكن مش حاسس بالألم وأنا صاحي. زي regional anesthesia. وممكن again and I can feel pain while you are not awake. For an example, if you are deeply asleep in your house after a long heavy duty, and somebody told you after that while you are awake, we came yesterday and we have tried to awake you many times, and you are not responding, and you will say, I'm not remembering that. If somebody is trying to awake me, yes, we are trying to awake you, but you are deeply asleep, and you cannot remember the trial of awakening. Okay, so I can have a sensation. I can lose my consciousness, and I'm still feeling pain. He can squeeze his skin. He can move his hands like this. He can make a grimace like this, and he is forgetting everything about the mental stimulation. And lastly, even more amazingly, Kaman, you can feel pain, but it's not annoying because pain is two component: annoying component and feeling component. If you make a frontal lobectomy, the patient will remember that he has pain, but it doesn't annoy him. So if I am conscious, I can see the surgeon cutting my skin or cutting my body. Don't worry. If you have a regional anesthesia as a patient, we'll put it like this figure, a screen or a shield in between you and the surgeon, where you will not see or feel anything. Okay. So what are the benefits of regional anesthesia? Firstly, it will reduce the potential side effects from GA like drowsiness, nausea, vomiting, or dizziness. Moreover, it will lead to early ambulation. If you have a regional anesthesia in your hand, so you can move easily after surgery, and even you can go home and discharge soon, and to resume the normal life as soon as. And so the admission discharge time will be very short. There's less incidence of DVT, less incidence of bleeding, and healthy baby if you have a pregnant lady that will take spinal anesthesia. Remember, regional anesthesia is not related to bowel problems like constipation, atony of the intestine, and vomiting and nausea. This is not related to the regional anesthesia. It's related to general anesthesia, and there's no relation between back pain and spinal anesthesia. It's a coincidence, and the only back pain that you will feel after spinal is the needle puncture that will resolve after 21 days, and not more than that. Not more than that. What is the problem with the regional anesthesia? The most common problem is the post-dual puncture headache with spinal anesthesia, and the most dangerous problem is toxicity, and I will talk about both of these topics later on. Allergy is very rare, hematoma 1 to 100,000, infection very low incidence, nerve or organ injury 1 to 10,000, so there is no fears of being paralytic or numbness or nerve injury with regional anesthesia. Is very rare. And specific to the procedure, like to puncture the pleura or to puncture the artery while you are doing regional anesthesia, which is also very rare. And by the modern techniques like ultrasound, this complication and side effects are totally decreased. I will now talk about the most popular, most common side effect, which is post-dural puncture headache. This commonly done with both spinal and epidural anesthesia. The incidence range is very wide. From 0.001% to 30% according to the type of the patient, type of the needle, type of the puncture, and it's unavoidable. If it will happen, it will happen. I cannot avoid. And lastly, it relates to the position. If the patient is standing, he will feel pain. If he is lying down, he will not feel pain. How to treat? Very easy. Firstly, you should reassure your patient and tell him that it will resolve spontaneously after in 90% of patients. And how to treat: bed rest, fluids, simple analgesic like paracetamol and caffeine. في مصطلح بالعربي بنقوله كده العيانين يعني واشرب ميه وقهوه كتير. اوكي يعني اغنيه كده يعني. How to prepare for spinal anesthesia or for regional anesthesia? Like any procedure, consent, verbal or written, describe to your patient, reassure him, prepare your safety equipment like rush trolley, put full monitoring, don't take it easy, everything could happen, put oxygen, the prophylaxis, good sterilization, and lastly, try to prepare intralipid and know its location. Why intralipid? Because it is the antidote of regional anesthesia toxicity. So we should have internet in the hospital, and we should know where it is exactly to bring it as soon as in case of toxicity, which is not common but very dangerous. Decision to whom I will give my regional anesthesia. I'm sorry, there's no decision. It's contraindication. It is a mistake. This is contraindication, no decision. Okay. If the patient refuses to make the regional anesthesia, this is absolute contraindication. If we have allergy from the drugs, we should not give the regional anesthesia. And relative contraindication in the patient selection, which type of patient I should select. If you have a young patient who is very anxious, or a psychopathic patient that will not tolerate to stand for a long time with the regional anesthesia. If we have a patient with renal impairment that he may go to toxicity earlier than the normal patients, so it's better to avoid regional with those patients. Surgery and the procedure, some surgeries are too not so fast, or they are talking loudly in the operation, they are shouting, so it's better not to let the patient know that they are very slow or they are shouting in the operation. Sometimes the surgery itself is a lengthy procedure, so it is not wise to put the patient in a lateral or prone position under regional anesthesia for 5 or 6 hours. And lastly, seniority. Sometimes the surgeon is senior and he needs to give the patient JA, and subsequently the anesthetist is obligated to give general anesthesia. Last thing is anticoagulation. It's a very long, very big topic. No need to go in details, but simply to know that if the patient is on anticoagulant, it's better to avoid regional anesthesia. How to localize the nerve? The most modern technique is the ultrasound machine. Now we can see the nerve itself directly, and we can see our needle. This is the nerve. This is the artery and vein, and this is the needle. This is tissue layers, skin, subcutaneous, and muscles. So now modernly you can see all the needle in trajectory, and you can feel itself on the nerve. This leads to a very low incidence of complications. If I have a dangerous organ like the artery and the vein, I can avoid them. If I have the pleura, I can go away from the pleura. So it decreases muchly the incidence of side effects. And lastly, second, nerve locator, very old machine using the electricity. So if the needle can be near to the nerve, it will elicit electricity, and the nerve will give an impulse, and the patient will switch his hand, move his hand like this, so I can locate the nerve. Paresthesia, very, very old technique. I will go by the needle over the nerve. I will puncture the nerve itself. The patient will feel numbness, and so I am sure I am on the nerve, but this is very injurious, and now it is obsolete. No more in use. Anatomy. Before the paresthesia, they are using anatomy to locate the nerve by the landmarks, and this is easy, but have a low incidence of success. And lastly, X-ray and CT for a deep structure like the spine. You see, I have the spine, and I can know that in this area I have a nerve root, and this is my needle, and I put the needle in the correct place, and I give a dye to draw in the nerve. This is the nerve after the dye. So I'm not seeing the nerve itself, but I can see the location of the nerve, and I can draw the nerve by the dye. And so I'm sure that I'm in the correct place, and I will inject my medication. Pharmacology. What medication I will use? It's not the time to discuss or to talk about the types of medications and side effects and those, but just remember I have 4 aspects to cover in my medication: which type of medication, which dose, which volume, and what is the dilution. Every item of those items will determine my block success and my duration of my block and the side effects. Lastly, I can put an adjuvant like dexamethasone, Presidex. These additives will prolong the duration of the block and may give benefit to the patient, that it will take a long time to resolve from the local anesthesia, and so that's lengthy surgery, or even to make a post-operative analgesia for a long time. Now I will talk about the local anesthesia toxicity, which is not so common, very rare, but very dangerous. How to have a local anesthesia toxicity if I give a drug overdose? or I inject directly to the vessel. So every time I'm injecting my medication, I should make a negative pressure to check that I'm not, to be sure that I'm not in the vein or the artery. Some areas in my body have a rapid absorption rate, like intercostal places. So take care if you give in this place intercostal place. If I give local anesthesia, it will be absorbed rapidly and in a big volume, and may lead to local anesthesia toxicity. Sometimes post-operatively, I put a syringe pump with a continuous infusion. So I may lose my mind. I may forget that by time this confusion will make a cumulative effect, and lastly, the patient will go to the local anesthesia toxicity. If I give multiple injections, time by time by time, like a continuous infusion, at the end the patient will go to local anesthesia toxicity. Symptoms. There are a lot of symptoms, tingling, numbness, but I need to describe the patient, what will happen in the patient in the OR or in the recovery area. First sign that will be numbness and tingling in the mouth, and this very very securing sign and not common. The patient will not remember or will not mention that he had numbness in his lips, and even he mentioned to the nurse or to the doctor, they will not take in consideration of the meaning of numbness in the lips. So first sign, numbness or metallic taste will pass by the patient, will pass by the nurse, will pass by the doctor. Then the patient will go to a stimulatory or excitatory phase. Will go to an anxiety and agitation, and this could happen for any patient in the anesthesia, under the anesthesia in the OR or in the recovery. And by mistake, we can think that he is anxious because he is afraid. Then the patient will go to convulsions and epilepsy. Usually, when we have a patient in the OR and he is anxious, or in the recovery, what we will do, we'll give him midazolam. So it will obscure, it will hidden the second stage, which is convulsions, and then the patient will go to the third stage, which is respiratory arrest and the cardiac arrhythmia and the collapse suddenly without precaution. So take care, any anxiety, any numbness, any tingling, any agitation in the patient with anesthesia, you should put in your consideration in your mind that he may go to a toxicity, and you should inform your doctor. You should prepare your crash trolley, and to know where is your intralipid, the antidote, and to prepare it as soon as. How to manage? Easy as any disease, as any toxicity. Stop infusion, call for help, and start your resuscitation ABC. And lastly, intravenous lipid emulsion. This is the antidote. What is the conclusion and the whole message? I will finish my lecture now. We know now the types of anesthesia, GE and local. We know types of regional anesthesia. We now know how to take a decision which patient should have regional anesthesia, what are the benefits, what are the problems, and lastly, pros and the cons of regional anesthesia. Any questions? Thank you. Stop still.